Burns are increasingly common in modern warfare. You need to know how to assess and treat burns as part of Tactical Combat Casualty Care, or TC3. During care under fire, casualties should be extricated from burning vehicles or buildings and moved to places of relative safety. Do what is necessary to stop the burning process, and then begin your assessment. First, determine the type and size of the burn and total body surface area affected. Burns cause the loss of the epidermal barrier, which leads to loss of moisture and fluids through the wound, loss of heat, a lack of protection from infection, and the elaboration of inflammatory mediators. Burn depth determines outcome in terms of scarring and survival. Superficial or first-degree burns are painful, erythematous, and blanch to the touch without blisters, such as a sunburn. Partial thickness or second-degree burns are erythematous, painful, and may blanch to the touch, and often have blisters. Full thickness or third-degree burns are firm, leathery, black, white, or cherry red, and painless. Fourth-degree burns involve other structures and organs beneath the skin, such as a muscle, tendon, or bone. They have a charred appearance that usually results from prolonged duration of contact with heat or fire. The rule of nines is used for estimating the size of a burn or total body surface area affected in adults. Each upper extremity is 9%. The head and neck are 9%. The lower extremities are each 18%, and the anterior and posterior trunk are each 18%. Another quick method is using the palm of the patient's hand. It is approximately 1% of total body surface area and can be transposed visually onto the wound for a determination of the burn size. Do not count superficial first-degree burns in calculating the TBSA burned. Facial burns, especially those that occur in closed spaces, may be associated with inhalation injury. Look for soot in the nares and mouth, voice changes such as hoarseness, and wheezy or whistling upper airway breathing. Suspect inhalation injury with prolonged exposure to smoke, and if there is no other traumatic explanation for their condition. These casualties are trauma casualties with burns, not the other way around. They may need hemorrhage control, resuscitation for shock, and treatment of pain for their associated injuries first. All routine TC3 interventions can be performed on or through burned skin in a burn casualty. If hemorrhagic shock is present, resuscitation for hemorrhagic shock takes precedence over resuscitation for burn shock. For casualties with trauma to the face and mouth, or facial burns with suspected inhalation injury, nasopharyngeal airways and extraglottic airways may not suffice. Consider early surgical cricothyroidotomy for respiratory distress or O2 desaturation. Aggressively monitor for any changes in airway status or oxygen saturation. After you have addressed any immediate life-threatening issues, you can proceed with burn-specific care. Initial treatment is to cover the burned area with dry, sterile dressings. For extensive burns greater than 20% TBSA, consider placing the casualty in a heat-reflective shell or the blizzard survival blanket in the hypothermia prevention kit, the HPMK, in order to both cover the burned areas and prevent hypothermia. Using the HPMK for burns greater than 20% is important, as burn patients may be very susceptible to hypothermia, especially during evacuation. Fluid resuscitation is guided by the U.S. Army Institute of Surgical Research Rule of 10. For a burn casualty with burns greater than 20% of their total body surface area and not suspected of being in hemorrhagic shock, initiate fluid resuscitation as soon as IV-IO access is established. Resuscitation should be initiated with lactated ringers, normal saline, or Hextend. If Hextend is used, no more than 1,000 milliliters should be given, followed by lactated ringers or normal saline as needed. Initial IV-IO fluid rate is calculated as the percent TBSA times 10 cc's per hour for adults weighing 40 to 80 kilograms. For every 10 kilograms above 80 kilograms, increase the initial rate by 100 milliliters per hour. Administer fluids and analgesia for burn pain in accordance with TC3 guidelines. Pre-hospital antibiotic therapy is not indicated solely for burns, but antibiotics should be given if indicated to prevent infection in penetrating wounds. Document all care rendered on a DD 1380. In summary, stop the burning process immediately. Move the casualty to a safer area. Facial burns may indicate inhalation injury, so monitor the airway and oxygen saturation. Cover burns with dry, sterile dressings and consider using the hypothermia prevention kit. Initiate fluid resuscitation for burns greater than 20% TBSA using the ISR's rule of 10. Administer analgesia for burn pain as needed.